Thank you, Dr. Ho. Good afternoon, everyone. So today, Avon and I we are going to present on approach to pancytopenia, which will include the introductions, and then we will give some examples of case studies. And then at the end of the presentation, we will focus more on the aplastic anemias management. So as introduction, as we all know that there are three main types of blood cells, all of which originate from the hematopoietic stem cells, which are located primarily in our bone marrow. So the red blood cells, white blood cells, and also platelets. So this can be summarized in this diagram. So bone marrow is basically our factory in producing all the hematopoietic stem cells, which can be further divided into myeloid and lymphoid progenitor cells. So from the myeloid progenitor cells, they will differentiate further into megakaryocytes, which essentially produces our platelets, then our white cells, which includes from eosinophils, basophils, monocytes, and also neutrophils, and also our red blood cell, which is the erythrocyte. So on the other hand, our lymphoid progenitor cells will produce our T cells, B cells, and also NK cells. So what is pancytopenia? The definition of pancytopenia is the reduction in all cell lines of blood, pan meaning all, and cytopenia, which means reduction in the cells. So by definition, WHO definition, the hemoglobin must be less than 12 grams per deciliter in women, and also 13 grams per deciliter in men. Whereas the leukocytes must be less than 4, and also platelets less than 150. So sometimes this may differ with laboratory measurements as well. So the main causes of pancytopenia can be divided into two main causes: central and also peripheral. So central can be due to many reasons, which essentially means it's central as in its decreased production of all the cell lines. This can be caused by bone marrow suppression. There may be some maturation defects of all the cell lines, and also ineffective hemopoiesis. And also there might be infiltration or the replacement of the bone marrow. So when this happens, the bone marrow itself cannot produce enough of all the cell lines of the blood. Another big umbrella of cause of pancytopenia will be the peripheral causes, which are mainly due to increased destruction, or it can be because of consumptive or sequestration or pooling of the blood cells. So the central causes, as I said before, there are three main causes, like bone marrow suppression. So this can be seen in aplastic anemia, where there is a suppression in the production of all cell lines. And also certain drugs, especially in chemo patients, where we use very cytotoxic drugs. So these can also suppress the production of all the three cell lines. Other causes include autoimmune diseases such as your SLE and also rheumatoid arthritis, and also viral infections. So certain viruses can also cause bone marrow suppression, especially as in HIV, where we see where pancytopenia is actually can be common in acute illnesses. So the second category in central causes will be the maturation defects or ineffective hemopoiesis, which means there are not enough fuel to produce all the three cell lines. This can be caused by nutritional abnormalities, where there is deficiencies in your B12 and folate. So this can cause a reduction in all cell lines because the production itself is inhibited. So other causes include myelodysplastic syndromes and also HLH. The last category will be bone marrow infiltration or replacement, where the bone marrow itself is replaced by your malignant cells, your fungal infections. So when the bone marrow is infiltrated, so this replaces the progenitor cells in the bone marrow, so there cannot be enough production in all the cell lines. So this can be divided into non-malignant and also malignant ones, such as your leukemias, multiple myelomas, lymphomas, which invade the bone marrow. So moving on, where we have central, then we now move on to peripheral causes. So peripheral causes is usually due to increased destruction, such as in DIVC, which is associated with very bad sepsis or even acute promyelocytic leukemia, APML. So all the blood, the cell lines will all be used up. So that is what causing all the pancytopenia picture. So other reasons can be due to TTP and also autoimmune causes as well. So another cause of peripheral cause will be sequestration or pooling of all cell lines, which can occur in splenomegaly where we have portal hypertension or cirrhosis, also caused by infections such as HIV, TB, or malaria. So it's important to evaluate the pancytopenia, and we always go by history, physical examination, and lastly, investigations. So how the presenting history of all patients can be variable, and this can also be from mild to life-threatening forms of presentations. So the presentation of pancytopenia usually reflects usually reflects the decrease in all the blood cell lines. So in decrease in the red cells, the patient will get anemia, will present with symptoms, and also in leukopenia, reduced white cells, they will have increased risk of infections, so they may come in neutropenic sepsis and so on. So in thrombocytopenia, because of the low platelets, they may be vulnerable to bruising, easy bruising, fatigue, also mucosal bleed. So in order to get a full picture of and to clinch the diagnosis, we should always ask the patients on the duration of the symptoms, whether the onset has it been there for quite some time, or this is something very rapid. So it often gives us clues to what causes the pancytopenia itself. So from the underlying causes, we can ask them like further on, is there any recent infections, or are they on recent, have they received any recent chemo or radiotherapy, or are they on any current treatment for any autoimmune conditions, or explore further history regarding their nutrition, any malabsorption, any possible chronic liver disease, so that as we can pinpoint more specifically what are the cause of the pancytopenia itself. So constitutional symptoms usually suggest malignancies. So this is important to explore as well. And if there's any relevant family histories, is there any inherited aplastic anemia, for example, can also lead us to the underlying cause of the pancytopenia. Social history is also very important, as the occupation, especially exposure to radiation or chemicals, can be a precipitating factor in the patient developing pancytopenia. So the physical examinations, again, it reflects the reduction in all the cell lines. So patient may have pallor, they may have easy bruising, you may see fatigue or mucosal bleeds, and patient may tend to get oral thrush because of the low, because of neutropenia, and also a very patient may also have gum hypertrophy, which it may be suggestive of APML. And also look for hepatosplenomegaly, because sometimes in like certain diseases like CML, and patients may present with very huge spleens, and it's important for us to catch that so that we can know the underlying cause. Again, any signs of chronic liver disease also is very important to elicit, because chronic liver disease itself can also cause pancytopenia. And lastly, also like patient have any lymphadenopathies, which may lead us to patient may have underlying lymphoma or chronic infections. So investigations further divide to the blood investigation, and also the biopsy, histopathological examination of relevant tumors. So for the blood investigations, it's very important to not only get a full blood count, but also to look at the differential counts and also specific red blood cell indices as indicated. And also the reticulocyte count itself is very important as it forms one of the criteria for us to diagnose aplastic anemia and so on. So it's also important to get a coagulation profile, especially if you suspect a DIC, and also get a fibrinogen level as well. Liver function test, a renal profile, and electrolytes as appropriate. And also we should screen them for any infectious diseases, especially hepatitis and also HIV, because HIV itself, can cause pancytopenia. So specific tests that we can order in order to get to the diagnosis, which will include B12 or folate levels, because as we all know, nutritional deficiencies can also cause pancytopenia, and so megaloblastic anemia, for example. If we suspect HLH, we can send for ferritin, TG levels, and also fibrinogen as well. And if we suspect a patient having an autoimmune cause to the pancytopenia, so it's important to send for autoimmune screens, such as ENT, for NTDS DNA. And also lastly, blood type and screen, which will always be important for us if patient require the transfusion in the acute setting, also in the future. So the one of the main investigation that we should send for if patient does have pancytopenia will be a peripheral blood film, because it can give us many clues and hints to what is the underlying cause. So for example, if we look at the peripheral blood film and then we see blast or any atypical lymphocytes, this can lead us to a malignancy as a cause of the pancytopenia. So if especially if we see a peripheral blood film reported as like leukoerythroblastic picture and so on, it may suggest bone marrow fibrosis or infiltration, because leukoerythroblastic means that they are outpouring of immature forms of your red cells and white cells. So that means that the marrow itself is crowded, and then this leads to over pouring of the immature cells to our peripheral blood. So it is also, if we see plasma cells in peripheral blood film, then this is most likely multiple myeloma, because plasma cells should not be seen in a peripheral blood film. And also in certain cases where we see hypersegmented neutrophils, like the picture on your right, where we have 5 or more nuclear lobes, then this suggests megaloblastic disorder, which can be seen in our B12 and also folate deficiencies. And the next investigation that we set, especially for especially if you're not sure if the patient is an aplastic anemia or leukemia secondary to the bone marrow infiltration, then it's always very important to counsel the patient to get a bone marrow X-ray as especially useful because we suspect there's a primary hematological disorder after ruling out all the other differentials. So this is not as helpful if we suspect peripheral causes of pancytopenia like SLE, and other peripheral causes, because the main thing that we can find in the bone marrow is the primary hematological disorder. So when we send for bone marrow X-ray, they will be under the microscope to see if there are any abnormal blasts, abnormal cells that can help us identify and diagnose a certain condition. So we can also send the bone marrow X-ray for IgE, immunophenotyping, cytogenetic testing for us to diagnose leukemias, MDS, and also lymphomas, very specific to the cell markers of the abnormal cells that we see. So we can also send for very specific tests such as CD59 flow cytometry to diagnose paroxysmal nocturnal hemoglobinuria. And also molecular studies are required. Other forms of investigation includes your imaging, especially patients who come with swellings, or lymphadenopathies. So we want to see the extent of it. It's also very important to stage the disease. And finally, to get the
Kucing aku masuk dalam engine, dah stop start engine.
and then we send this for histopathological examination
So aku
to have
bagi
what
pengajaran.
exactly is the underlying. So, what are the associated with pancytopenia? So, if you know that neutropenia, especially if ANC is less than 1, this shows that it's quite a bad neutropenia. So, especially if it's very severe, ANC less than 0.5, or it's a new discovery, like new incidental finding that ANC is less than 1 even on presentation, then this should be a red flag to quickly refer to hematology. And also, if there's a very low thrombocytopenia, sorry.
So you just need to mute the participant mic a bit confusing.
Okay. So also some emergencies associated with pancytopenia can be very low platelet counts, such as less than 10, especially with clinically significant bleeding, such as your intracranial bleed. Also UGIP with especially with platelets less than 50, then you should quickly refer. And also if there's suspected DIC, this is also a type of emergency that can occur with pancytopenia. And also suspected acute leukemias and very severe aplastic anemia, as we will discuss later. And if there's suspected HLH, then other emergencies can associated with primary hematological disorder that can be associated with pancytopenia include your hypercalcemia in the setting of multiple myeloma or metastatic cancers and also lymphomas. Then your AKI and also hyperuricemia. So next we'll move on to 3 case studies that we compiled to illustrate to you all about pancytopenia and our approach to it. So the first patient is a very interesting patient also. He's DE. He's a 17-year-old student. He was very active previously, no medical illness. So initially he presented in December last year with provoked gum bleeding. Meaning after brushing teeth, then you have some gum bleed. So he went to GP and then found that initial FBC was he has pancytopenia. HB at that time was 3.9, total white 2, platelet was on 6, and ANC at the time was 0.8. So on examination, he was very pale, but there is no remarkable findings. There's no palpable liver or spleen or any lymphadenopathies. And at that time, he and his family was counseled for BMAT, but unfortunately, they refused. So he was discharged after symptomatic transfusion. So subsequently, he presented again to Hospital Keningau, like about 2 weeks later, with severe headache, vomiting, and blurring of vision. So an emergency CT brain was done, which shows subarachnoid hemorrhage. So subsequently, in what we proceeded with, this time they were keen to do a bone marrow X-ray and troponin. So it shows that it was hypocellular with less than 10% cellularity, and there was normal hematopoietic cells, but they are markedly reduced, and megakaryocyte is essentially absent. And there is no lymphoid aggregates or nodules, and also there is no excess of blast found in the bone marrow itself. So this is a very typical picture of aplastic anemia, which is a hypocellular bone marrow, and all cell lines are markedly reduced, and there is no excess blast. So our impression at the time was aplastic anemia. But when he transferred over to our hemato ward in Queen, his stay was further complicated with a lot of issues at the time because he was aplastic. So we actually had to arrange to get a very urgent stem cell transplant for him, as he presented with very severe aplastic anemia. So he was bleeding everywhere, basically to say that he had hematuria in ward. There was also hematoma on the in the mouth, bilateral buccal mucosa. The eyes were also involved in multiple pre-retinal hemorrhage. So we referred to an ophthalm team, and there was indeed a bilateral eye, subconjunctival, and also pre-retinal hemorrhage with grade 3 papilloedema as well, likely secondary to the SAH that he had earlier. So because of his low counts, low red cells, and also low platelets, so we had to transfuse him with a lot of blood products. So unfortunately, he developed a condition, what we call platelet transfusion refractoriness, where he had antibodies towards other people's platelets. So the platelet counts do not go up as high as we wanted it to, even with transfusion. So we had to get special cross-match platelets from the Pusat Darah Negara, and only then that can help to increase his platelet, but only for a short while, because platelets have lifespan is also not very long. So he actually, we started him with some medication that we call L-Thrombopag, and he had some bilateral calf pain. So this was probably due to the L-Thrombopag itself. Later we will explain what is L-Thrombopag. So because of the low white cell counts also, he was very neutropenic. ANC was very low. Initial one was already 0.8. So he had multiple septic episodes in ward, multiple spiking temperatures. Then cultures, although no growth, but he still had a lot of temperatures in ward. So we started him on IV antibiotics. So fortunately for him, we got an urgent HLA typing done. Then he was fully matched with his younger brother. So we quickly referred him to Hospital Ampang for allogenic stem cell transplantation, which he just completed last month. So that is the first case study to illustrate to you that pancytopenia can, so a bone marrow aspirate and trephine is very important to help us clinch the diagnosis of aplastic anemia. So the next case study will be Mr. R. He's a 29-year-old cargo officer, also a very healthy, previously no medical illness patient. So he presented quite differently from our first patient. He had on and off fever for the 2 weeks prior to admission, also with provoked gum bleeding, and this time he had loss of weight, he says, for at least 2 months prior. But otherwise, there is no bleeding tendencies, there's no night sweat or TV contacts. So the initial FBC again at GP shows pancytopenia, although not as bad as the first patient. HB was 9.6, total white 1.7, platelet was 67. And again, his physical examination was fairly normal. There were no palpable liver or spleen or any lymph nodes felt. So when he was sent over for further management, his infected spleen, his leptomalaria workup was negative, because we suspected initially, can this be pancytopenia because of some infections? So repeated FBC again shows pancytopenia. And very interesting thing is that his reticulocytes was 0.03, which is only 1.3%. So it's actually quite low. But blood CNS grew Staphylococcus capitis incidentally, but we treated him with IV antibiotics in ward. But the main thing that I would like to point out here is his peripheral blood film. Because of the pancytopenia, we sent for an urgent PBF, and it came back as 9% blast cells. So this should raise red flags on whether this can be an acute leukemia presenting with pancytopenia. It must be noted that not all leukemias present with high cell counts. They can also present with very low cell counts of all cell lines because of the bone marrow infiltration. So again, DMET and IPT was done. So this time it was reported that it was consistent with acute myeloid leukemia. So he was agreeable for chemotherapy. So he was quickly started on induction chemotherapy, DA3+7 regime, and he's now currently still in work to receive the treatment. That's all.
Okay. Hi everyone. Now we'll continue with case study number 3. So this patient is 16 years old, very young girl, actually no medical illness as well. Initially presented to the district hospital for anemic symptoms, more to a reduced effort tolerance, pre-syncopal attack, but clinical examination are unremarkable. No hepatosplenomegaly, no limb actinopathy as well. So initial cell counts noted pancytopenia, HB of 7.6, white blood cell of 2.2, very low ANC of 0.4, platelet of 18. So in order to rule out all the nutritional deficiency, iron study, including transferrin saturation, vitamin B12, folate was sent, and they were all normal. So of course, PBF was sent. Just the report was reported as pancytopenia, no abnormal blasts or lymphoid cells. That time, because of the young age, so a bit worried of BMAT, so she refused, and she was discharged after the blood product transfusion. So after 1 week, unfortunately, she's been admitted to a district hospital again for the similar complaints of symptomatic anemia. And full blood count repeated at times, still noted persistent pancytopenia of HB 5.5, white blood cell 2.3, ANC of 0.28, platelet of 7. So this time she finally agreed for bone marrow refined biopsy. So bone marrow aspiration done is actually suboptimal study. So it's unsuitable for assessment, but luckily the refined biopsy was able to read as a hypocellular bone marrow with features suggestive of aplastic anemia. So subsequently, she was transferred to over here for aplastic anemia. So due to her young age, ATG cyclosporine is not started. The first line will be the stem cell transplant. So she actually has 5 siblings. We tested 3 siblings as is not HLA compatible. So 2 siblings has already taken the HLA typing as well. So just hopefully the remaining 2 siblings have a compatible HLA typing. So she could be sent over to Hospital Ampang as well for stem cell transplant. So she's currently still in the ward, just for supportive therapy, including blood product transfusions, as well as antibiotics for all the neutropenic sepsis. Yep. So this one was, sorry, this is actually, okay. So last case study 4 is a 60-year-old lady actually referred from clinic to our hemato clinic for pancytopenia as well. 60-year-old lady with underlying diabetes, dyslipidemia, cervical cancer stage 2B, which has a disease-free for 21 years after with undergo radiotherapy, but unfortunately had radiation colitis and cystitis, and also a hepatocellular carcinoma with liver cirrhosis, complicated with grade 1 esophageal varices. So on elective admission during the case, noted the pancytopenia as well. Hemoglobin of 8.2 with microcytic hyperchromic type. Platelet of 121, not that bad. White blood cell of 1.8 and C of 1.15. So as usual, the PPF infective screening, the nutritional panel was sent, and as well as autoimmune screening. So the vitamin B12, folate, iron study were all normal. Sorry, the iron study was low. TFT is normal. Autoimmune screening is normal as well. So in hematoclinic, he is having on and off hematuria due to the radiation cystitis. But in terms of clinical examination, actually there's no hepatosplenomegaly, lymphadenopathy as well. So PPF is reported as generally hypochloremic microcytic anemia. White blood cell is leukopenia, but actually there's no blast or immature granulocyte can be seen. Platelet is reduced, no clumping, around 20 to 25 high power field. So ferritin at the time was low, 16.2, but actually there's no T-sep sent. So our impression at the time is actually pancytopenia due to the underlying malignancy as in liver cirrhosis, hepatocellular carcinoma with portal hypertension. So we did not proceed with BMAT. Our strategy will be monitor the cell counts, opt for the watch and wait strategy for now. So yeah. Our last session will be aplastic anemia. I will talk about some aplastic anemia. What are the criteria to diagnose it, the severity, as well as the management, how it differs from the age in terms of functional status wise. So definition of aplastic anemia will be a pancytopenia with hypocellular bone marrow in the absence of abnormal infiltrate or marrow fibrosis. So criteria to diagnose it, we have two. It's either peripheral blood or from bone marrow itself. So from peripheral blood, NC will be less than 0.5, platelet less than 20, and also a reticulocyte less than 1%. For bone marrow criteria, bone marrow cellularity have to be less than 25% or moderate hypocellularity 25 to 50%, only if the 30% of the residual cells are hematopoietic. So the classification-wise, for aplastic anemia, we have classified into non-severe, severe, and also very severe. So non-severe, it doesn't meet any of these peripheral blood or bone marrow criteria. It just presents as a pancytopenia. Severe, you have at least two peripheral blood criteria with at least one bone marrow criteria. Very severe is with the severe criteria with NC less than 0.2, absolute NC less than 0.2. Yeah, so for the treatment-wise, it actually has three strategies. It's either anti-thymocyte globulin, cyclosporine, or allogeneic bone marrow transplant. We decide this treatment based on this age, based on the patient age, activities of daily living, and of course the most important is the availability of the HLA compatible siblings. So anti-thymocyte globulin indicated for only those patients does not have any donor bone marrow transplant that is compatible. And also for the non-severe patients that's dependent on blood products transfusion, or severe or very severe, like I said, with more than 30 or more than 40 years old, with lack of HLA compatible sibling donor. So of course, before we give ATG, we have to exclude the infections, exclude the cardiac disease by ECG or echoes. And also he had a very high risk of anaphylaxis. So usually we'll give a test dose at day 1. So after the ATG, few antibiotics and antifungal must be given for at least 4 weeks, which includes Cipro, fluconazole, and acyclovir. So take note that the ATG, the response takes around 3 to 4 months before we can see the effect. So the side effect of ATG, if we group into immediate or later, so immediate effect will be pancytopenia and also fluid retention, which includes acute pulmonary edema and heart failure. So it's very important before starting ATG, you must make sure echo is done, LVS preserved, and also as well as transaminitis, presence of anterior set antibodies. So this side effect will actually make difficulty in cross-matching blood products in the future later if we want to transfuse blood to these particular patients. So for the later side effects later will be all the rashes, your proteinuria, glycosuria, because the HCG regime itself contains steroid as well. So it can cause proteinuria and glycosuria. Worsening of the autoimmune thyroid disorder, GBS, and also the HCG actually itself is a chemotherapy drug itself. So it actually increases the risk of other blood malignancy like myelodysplastic syndrome, acute myeloid leukemia, solid tumors. So move on to the next treatment with cyclosporine. So usually after we give the cyclosporine, you have to measure the trough level on day 3 to day 7. So if the trough level is not toxic, so usually we will monitor weekly for months, then monthly. So our target trough level will be 150 to 250 microgram per liter. So the side effect actually is as AKI, the serum creatinine actually will slowly rise up. But our limit is around 130 micromole per liter. So if it's more than that, you have to adjust the dose of the cyclosporine as well. So the effect of the cyclosporine actually takes around 6 months. So if usually after a few months, we see the full blood counts have positive response, then usually we'll try to maximize the dose of the cyclosporine. In the meantime, make sure it's not above the toxicity level. Then once the FBC counts plateau, then we'll tail off slowly. So rapid dose reduction actually has high risk of relapse. So some patients also will need long-term low-dose cyclosporine. So in this particular patient, then have to take the trough level. So the cyclosporine side effects, nephrotoxicity, our electrolyte imbalance will be hyperkalemia, hypomagnesemia, and also hypertension, transaminitis as well, anaphylaxis, and also hypertrichosis. So the final management will be allogeneic hematopoietic stem cell transplantations. So this actually only indicated for those less than 40 years old with HLA compatible sibling donors, and usually given for those starting from severe aplastic anemia. So how do we see the response after treatment? So if we start from this, you look at this table. The no response, of course, is the worsening of the pancytopenia or no improvement of pancytopenia. So initially, if the patient had the non-severe aplastic anemia, a partial response, he or she have to meet either one criteria, or either is transfusion independent, or normalization of at least one cell line, or increment of HB more than 3, only if the initial HB is less than 6. NC must increase up to more than 0.5, platelet more than 20. So for severe aplastic anemia, a partial response have to be transfusion independent, and also the previous criteria of severe aplastic anemia is not met. So for complete response, of course, the hemoglobin will be normal for the age, NC more than 1.5, platelet count more than 150. So all this treatment actually, it takes around 3 to 6 months to see the effect. Yep. So the most simplified algorithm will be see the age and also HLA identical siblings. Okay, let's say the age of the patient is more than 40 years old. So we don't usually offer stem cell transplant. We will proceed with anti-thymocyte globulin or cyclosporine. So if patient has no response, we can offer a second dose of ATG. So if no response, the maximum will be the third ATG and novel immunosuppressive therapy. Okay, or just supportive therapy. If the patient is less than 40 years old, if you're lucky you have get the HLA identical siblings, then we'll proceed with the stem cell transplant. If there's no HLA identical siblings, then the algorithm will be same as the patient those more than 40 years old. So in summary, the presentation of pancytopenia can be various, including thrombocytopenia, bleeding, anemia, symptomatic anemia, and also fever for the past 1 month, 2 weeks because of neutropenia. So the bleeding can be harmless provoke bleeding or very life-threatening bleeding, as illustrated in the second case, spontaneous subarachnoid hemorrhage. So of course, you must remember that pancytopenia is not a diagnosis, so you must find out what causes it. Yeah, I think that's the last slide from us. Thank you very much. If any question, you have any question to ask? Yeah.
Thank you, Evan. Thank you, Chua. Anyone have any burning question? Your inquisitive minds, anything you want to clarify with that with the hemato team? Now this is the time to ask. I think we got about 60 plus people here, which is quite a record. So yeah, and just shoot ahead the questions to the presenters. Maybe Dr. Lim want to add on anything? Oh yeah, I think you all were talking about thrombopet earlier, but you all never elaborate that. Did you all elaborate? I forgot about it.
Maybe Chua can elaborate on the thrombopet.
So thrombopet is actually a non-peptide thrombopoietin receptor agonist. So its main function is to attach to the receptor and then stimulate the early cell lines so that it can hopefully improve cell counts to stimulate it to form the cell lines. But sometimes it can be successful, but sometimes also not.
Actually, L-thrombopet is what L-thrombopet to our platelet is what erythropoietin to our red cell is like stimulate the bone marrow to produce more of the platelets. So I think Chua and Ava have done quite a good job to present on pancytopenia. It's a broad topic, but I think the most important, because when we get the referrals, what we usually want to know is the PBF, especially in emergency cases, like just now as stated by Chua, the urgent cases that we need to send for urgent PBF, especially when we suspect there's leukemia, severe aplastic anemia, in sepsis. So most important is get the PBF. So sometimes the most important is communication. So have to call the lab to run the peripheral blood film urgently to look for any blasts and things like that lah. Yeah. Okay. Yeah. Thanks, Jason, for the comment. Are there any more questions? If not, we'll call it a day. Yeah. It's quite late now, 4:15.
4:15 is 4:15.
Yeah.
Any more questions from the floor?
If not, we'll continue our word rounds.
Okay, hold on. If there's nothing much, I think there's not much announcement. Only a few things here. I think next Wednesday is our morning. There will be a first medical and radiology conference lah. It's gonna be. I think it's been a while since we have a radio and medical conference meet. It's gonna be a physical meeting in the radiology department. I think there'll be 5 cases. I think whoever is interested can. I mean, whoever is been presenting will be there already lah. Just to let you all know. And then the other thing is from the on-call side, there's only starting from this month, there's only 2 physicians on call per day. The first call will be taking care of the referrals from district and the ED. Second physician call will take care of the inpatient referrals, the wards, and also any COVID cases referrals and management of the COVID cases inpatient. Just to let everyone knows about that, the changes. Anyone still have some announcements from any specialists, any consultants, or even any MOs or anything? If don't have, in the count of 3, I think we will end our CME today. Very thank you to the hematological team, Evan, Chua, for the excellent presentation. And hope to see you guys around and meet you all next time in the next CME. Thank you and have a nice day, everybody.
Thank you, everyone. Thank you to the whole.
Thank you.